Right, so MLA presentation 4, Behaviour and Personality Change. This could be a vast presentation and we're confined to about 10 minutes. So I'll try and sort of give you the broad strokes. So behaviour and personalities is innate to all of us. We all have different behaviours and personalities and we all respond differently to environment. I suppose the question is, when is behaviour and personality change pathological? And we need to consider different factors here, and there can be lots of nuance. The tempo, the speed of onset is important, and we'll come back to that again and again. And other features of illness can help inform whether or not this is a response to environment which is normal for that person, or whether or not there is an underlying illness causing the changes. So we always use the structure. So a hyperacute onset, very, very sudden. So if something is instantaneous, we tend to think that something is vascular. Okay. Also, injury and hypoxia can be very, very sudden. Hypoxic brain injury can often be caused by a sudden collapse with a cardiac event, depriving blood going to the brain. And usually that also produces a coma or loss of awareness. Traumatic head injury, you would usually have a history of that, and you would have signs of injury when the patient arrives to your care. But when we think about vascular causes, we tend to think about embolic stroke, and we tend to think about bleeds. Generally, you would have other clues to that. You might have weakness, numbness, other focal neurological deficits, but there are certain times when you might get a stroke or a bleed that causes a pretty isolated personality or behavioural change. Or if somebody is very agitated, you might struggle to do a proper examination, which can make things more difficult. If they have risk factors for a bleed, like high blood pressure, or for a stroke, high blood pressure, cardiac problems, diabetes, that can be helpful as well. Localization is important. So if you have a bleed or a structural problem or a stroke in a particular part of the brain, you would expect different manifestations and different behavioural changes. You can have delayed personality and behavioural changes after a stroke. For example, apathy, depression. If you have a seizure, which you can have after a stroke or due to other reasons, you can also have a post-ictal depression or even psychosis. So these are important things to consider. Delirium also is extremely common. So this is a patient who had a significant bleed, which involved the frontal lobe and the motor strip. So they had right-sided weakness and quite profound personality change. They were disinhibited, so they were sort of acting in ways that were inappropriate, sort of smacking people's bottoms and saying, unkind things which were uncharacteristic. And this is the sort of thing that we would tend to see in frontal lobe pathology. People can be both apathetic, where they're sort of withdrawn and not motivated to do things, but they can also have sort of socially inappropriate behaviour. So subacute onset, so over sort of hours to days. Stroke would be less usual, but you would think about things like infection. You would think about things like autoimmune mediated processes. So in neurology, quite often if people are confused and agitated, if they have headache, fever, and possibly seizures, encephalitis is something we consider frequently. Meningitis, particularly if they also have neck stiffness. This can also be sort of tied up with delirium, because people can have infections in other parts of the body, but they can become disorientated and confused. So it can be, we frequently get referrals in neurology for a possibility of encephalitis, and we find infection in other parts of the body that have caused the confusion. An inflammatory lesion, such as an MS, demyelinating lesion, particularly in the frontal lobe, can cause the same sorts of problems as any other sort of lesion in the frontal lobe. You might get apathy, disinhibited behaviour, but also problems with leg function as well. And psychiatric illness obviously can cause personality change. And you would not expect to have things like seizures, other focal neurological problems like leg weakness or arm weakness, and psychiatric illness. Drug use in both hyperacute and subacute presentations can also cause personality change, and that encompasses withdrawal, and it also can be due to secondary effects of drug use. So cocaine, for example, increases the risk of stroke. In chronic or progressive personality change, particularly in neurology, we consider things like dementing illnesses. So Alzheimer's can cause early depression, apathy, anxiety. Parkinson's disease and Lewy body dementia, which is a subset of a Parkinsonian illness, can cause quite profound, uncharacteristic anxiety early on. And FTDs, or frontotemporal dementias, they cause the sort of disinhibition and apathy and inappropriate behaviour of other sort of lesions in the frontal lobe, but you might also see atrophy in the frontal lobe. And they sometimes also develop preoccupations. If you have a slowly progressive change in behaviour, together with other features such as headache, seizures, limb weakness, then we think about things like a tumour, particularly in the frontal lobe. Neurodegeneration can have psychiatric features, as I've just touched on, but also depression in itself can mimic dementia, and we call that pseudodementia. So psychiatrists are always aware that treating depression is important, because treating depression in certain people can resolve their memory and personality problems. So in summary, if we have a very rapid personality change, instantaneous, then we think about a vascular problem, particularly if there are other features or other deficits that can be localized to a lobe of the brain or an area to the brain. Sudden injury, particularly frontal lobe injuries, can cause profound personality change acutely. We would generally have other signs of injury, and we would have a history of a fall or a road traffic accident or similar as well. And hypoxic brain injury after deprivation of blood supply to the brain can also cause personality changes, but often coma as well. Always think about drug intoxication. Do a tox screen if you're not sure. If things are fairly acute, together with fever and other features, think about encephalitis, think about inflammation. Chronic or progressive personality and behavioural changes can be due to psychiatric illnesses, but they can be due to dementias. And looking for other features of dementias are important. Treating depression appropriately and rapidly is important. And whenever people particularly have chronic or progressive personality and behavioural change together with signs of dementia, we always look for reversible or treatable causes. And you'll hear about things like testing for HIV, testing for syphilis, doing a scan to make sure there isn't a treatable tumour. These are all very important in what we call a dementia screen. And that is a rapid approach and a way to think about personality and behavioural change. Thank you.